Hi, my name is Sultan Türkmen Keskin. I want to briefly introduce myself. I worked as a service nurse for 8 years in pediatric cardiovascular surgery and pediatric surgery wards, and then as nurse supervisor for 2 years. I have been working a lecturer at Ankara University since 2014. I want to start my presentation. We conduct our study with Dilek Ekici at Gazi University. Our study title is Development of a Patient Classification Scale specific to the Pediatric Surgery Service. Patient classification tools, one of the methods used in planning nurse labor force contributes to the process of taking decisions related to planning nurse personnel based on units or institution by classifying patients in line with their personal care needs in certain period of time. These systems measure the nursing care activities that patient recur with either 24 hours or as part of the nursing workload. Include direct and indirect nursing activities and nursing care hours. Patient classification scale are used in order to determine care durations, nurse workload, the most appropriate care for patients, personal recruitment, and care costs recurred for patients. In the literature, there are many patient classification scales such as Rafaela system, the old patient classification, Perrock's patient classification instrument, the Cheltenham patient classification scale, and the nursing activity score. Studies on the patient classification system in Turkey are limited, and there is not any classification tool specific to pediatric patients. The number of nurses were planned according to the number of beds in hospitals in Turkey, but this method is insensitive the patient's individual needs. So the aim this study was to develop a patient classification scale to be used in determining the nursing intensity of patients in the pediatric surgery department of the university hospital and planning nursing manpower. Methodology, the study was conducted in the pediatric surgery service of a university hospital in Ankara, Turkey. This service has a total of 76 beds, two of which are incubators and 2 of them are outpatient surgery. Pediatric patients age is 0 to 18 years. Total nurse number in this service is 7. All these nurses have bachelor's degree. These nurses, 4 of them have been working more than 10 years. 2 of them have been working between 5 to 10 years, and 1 nurse has been working less than 1 year in pediatric surgery service. The data were collected between April 2017 and November 2018. 503 patients were included in the study to examine inter-rater reliability. 301 patients were included for construct validity and confirmatory exploratory factor analysis and confirmatory factor analysis and internal consistency reliability. 6 stage for instrument developed as follow. Stage 1, based on the literature, the researchers determined 1-dimensional and 12 main care areas specific to pediatric surgery patient. The main Care areas of the draft scale define nurse-patient dependency, nutrition, respiration, elimination, drug treatments, vital signs follow-up, procedures, personal care, activity and movement, skin and mucosal integrity, training and guidance, physical comfort, and safety. Subcare indicators were defined in which the intensity of patient care range from 1 to 4. As the total score obtained from the draft scale increases, the patient's needs and the level of patient's dependence on the nurse also increases. Stage 2 service nurses were trained on human resource management and use of importance of the patient classification scale. Of the 4 nurses who agreed to participate in the research after education, 1 nurse took part in the data collection process with researcher, and the rest 3 took part in the development of the draft scale expert. The first version of the draft scale was the opinions of 3 faculty members who were experts in nursing and in pediatric surgery, and 3 nurses working in the pediatric surgery service. At the end of individual meetings, experts report that 12 main care areas on the scale were ideal for pediatric surgery service. However, 3 specialist service nurses and a faculty member state that it would be more appropriate to divide patients into 5 groups rather than 4 according to the intensity of care. When creating care groups, the time and emotion and physical energy spent by the nurses to complete a task, expertise, and the frequency and follow up the practice matter. Since the scale aims to measure nursing activities with the patient classification scale, acceptance of the scale by service nurses is very important. Therefore, the draft scale was revised in accordance with the suggestion given by experts. In line with expert recommendation, there areas involving daily living activities and the area of training and guidance were added indicators to determine parental involvement in care. Also, the nutrition care area on the scale was changed to nutrition and hydration. The scale was rearranged by adding administration of the and enema to the elimination care area, patient with peripheral catheter inserted skin and mucosal integrity care area, and the use of incubator to the safety care area. Second version of the dress scale were determined 5 categories, 12 main care areas, and 60 sub-care indicators. The draft scale was deployed by the researcher and 3 service nurses between 3 to 23 April 2017. It is very important to create a valid institution-specific patient classification scale approved by the service nurses. Data recorded between May 2017 and November 2018 on weekdays and weekends in 0800 to 16.00 and 16.00 to 24.00 shifts. The first data was collected for inter-rater reliability between the evaluators, and a total of 503 data were reached. During the data collection process, the time between the 2 evaluations was taken into consideration as the clinical conditions of the patients may change. Besides, the patients were evaluated independent from each other, first by the service nurse, then by the researcher. Then the researcher went on collection data for construct validity and internal consistency reliability of the scale, and the data collection process was terminate after research 301 data. The data was analyzed, the contract validity, internal consistency, and inter-reader reliability. The last version of PSSPC consists of 5 categories defining dependency of patients on nurse and 11 nursing main care area on totally 55 sub-care or indicators. The highest score to be taken from the scale is 55 and the lowest is 11. Patients are classified under 5 care groups according to total score they have obtained as follows. According to the literature, first level refers to minimum care, second level medium care, third level high care, fourth level semi-intensive care, 5th level intensive care. Statistical analysis of data were administered by statistical packet for social sciences 25 point of program. Inter-rater reliability was assessed throughout Cohen's-Kappa coefficients. The construct validity of the scale was evaluated with explanatory factor analysis and confirmatory factor analysis. The loading cutoff value of each item was 0.30 or higher in EFA. Reliability and consistency analysis of the scale were assessed utilizing Cronbach alpha coefficients, Spearman-Bros relation coefficients, and Gutmann two-half coefficient. A significant levels was accepted as 0.05. This study was ethical approved in 17 March 2017. Results. The developed draft scale was scored by 2 raters on the basis of 503 data. The inter-rater agreements for 12 care areas on the scale was achieved with Kappa coefficients. Cohen's-Kappa test was administered in order to test whether each patient was considered at the same level by the raters. According to Landis and Co., the Kappa coefficients between 0.61 and 0.80 substantial, and between 0.81 and 1.00 almost perfect fit. As seen in the table, while training and guidance had the lowest Kappa values in the scale, vital signs follow-up had the highest Kappa value. In the literature, similar to the results of the study, it seems that inter-rate agreement related to the physical care areas such as restoration, treatments, vital signs were higher compared to training, guidance, coordinations, emotion support, which are more abstract and recurring individual decision-making. According to independent t-test results, there was not any statistically significant difference between mean scores of both raters, all care areas, and total scale scores. In other words, scale total scores were not statistically different from each other according to raters. Using the data obtained from the 301 patient principal components analyzed and Varimax rotation used in the EFA were performed to determine the factor structure of the scale. As a result of the analysis, it was found that the factor loading of the training and guidance item was lower than 0 0.30. Therefore, the explanatory factor analysis was done once more by removing the training and guidance item. Kaiser-Meyer-Olkin statistics and Bartlett's-Spritzky test results show that a sample size of 301 individuals was adequate and appropriate for doing a factor analysis. When the total variance explained in table 3 were examined, although the factors with eigenvalues greater than 1 were observed in the 11-item scale. The graph of the eigenvalues showed that there was only one dominant factor. It was observed that this single factor measurement tool achieved measuring 41.45% of the feature that it aimed to measure. Asian values chart. Accordingly, it can be said that the ratio of explained variance of the scale is adequate. The factor loading values of the items in the factor emerging after the second EFA was above 0.30. Based on the explained variance ratio in item factor loading values, it is possible to say that the structural validity of the scale was achieved. A confirmatory factor analysis was also performed for the 11-item single factor scale items according to EFA results. As a result of failure to meet the assumption of multiple normality between items, the parameter estimation was performed using the asymptotic covariance matrix with the robust unweighted least squared method. The paid coefficients considered as factor loading range from 0.38 to 0.84 and were not low. The model data fit indicates of the 11-item single factor scale are shown in the table 3. The goodness of fit indicates were used to decide whether the observed data fitted the one-dimensional model. As seen in table 3, the fit indicates were found at or above the acceptable limit. In other words, the validity test of the 11-item single factor scale was verified according to fit indicates of the confirmatory factor analysis. Accordingly, it can be said that the scale model had goodness of fit. The analysis of internal consistency reliability with the data from 301 patients. Cronbach alpha internal consistency and Spearman-Brown and Goodman split half reliability coefficients of the scale were found to be 0.831, 0.771, and 0.857 respectively. These results were above 0.170, which is an accepted value in the literature. The item total correlation of the scale items, also known as the item validity coefficients, range from 0.283 to 0.748, and the elimination items was found to be below 0.30. Conclusion, using valid and reliable measurements tools in planning nurse manpower and evaluation of effectiveness of nursing care has great importance in providing evidence-based data. The results of this study show that the scale developed specific to this pediatric surgery service is a valued and reliable measurement tools in the classification of patients according to their care needs. Thank you for listening to me.